Before we go straight to the anatomy, it is important to know the normal density of chest radiograph. The lungs, which are largely composed of air, appear dark on radiographic image due to more X-ray radiation reaching the machine detector following low absorption of the radiation by lung tissues. On the contrary, the bones, being high-density structures, appear very bright due to high absorption of the X-ray radiation by the bones themselves, leaving less X-ray reaching the detector. In general, the density of the soft tissue structures will be somewhere in between the lungs and bones. Anatomically, the lungs are divided into 3 lobes on the right and 2 lobes on the left. However, on chest radiograph, each lung may be grossly divided into upper, mid, and lower zones, each taking 1/3 of the overall height. Remember, zone in this context is not interchangeable with lobe. 2 lobes of the same lung may overlap and share the same zone. It is advised to start with zone when describing a pathology on the chest radiograph first, before a specific lobe can be pinpointed whenever possible. Within the lungs of a normal chest radiograph, one can observe lung markings, which are mainly made of vessels. The airways are filled with air, hence their density are generally inseparable from the surrounding lungs. The markings taper in caliber from the hila to the periphery. When there is pathology causing thickening of the surrounding interstitium of the walls of the vessels and airway seen, the term increased bronchovascular markings may be used, given that the outline of the thickened airways are also seen. Lungs are covered by visceral and parietal pleura. The fissure is double-folded visceral pleura that either completely or incompletely invaginates the lungs. The fissure separates the lungs into lobes. On chest radiograph, the transverse fissure is usually seen as a thin horizontal line across the mid-zone of the right lung, whereas the oblique fissures are not seen given they run obliquely and not parallel to the X-ray beam. Fissure is an important landmark for chest radiograph interpretation. For example, the transverse fissure may be pulled towards a collapsed lung lobe or thickened due to effusion or interstitial fluid. Anatomically, hila are lung roots consisting of bronchi, vessel, nerves, and lymphatic channels. The hila shadow on chest radiograph are generally made of proximal pulmonary veins and arteries, as well as lymph nodes. The hilum is enlarged and the hila angle is obliterated in cases of hila mass, lymphadenopathy, or pulmonary artery dilatation secondary to pulmonary hypertension. Other than the borders of the cardiac silhouette, the details of the cardiac structures themselves are not seen as separate shadows. The right cardiac border is largely made of right atrium and superior vena cava from below to top. The left heart border is largely made of aortic arch or knuckle, pulmonary arterios conus, left atrial appendage, and left ventricle from top to below. The heart is projected at the center, usually 1/3 on the right and 2/3 on the left. On normal radiograph of posterior anterior projection with good inspiration and no significant rotation, the cardiac size should be less than 50% of the thoracic diameter. Cardiomegaly is labeled when the cardiothoracic ratio is more than 0.5. Upper limit of 0.55 is used for Asian and African population. Other structures that can be seen on chest radiograph include the dome of the diaphragms. The right hemidiaphragm is usually higher than the left. Structures like breast tissue for female patients, bones, including the spine, clavicle, scapula, and the proximal humerus, and gases in the upper abdomen, such as the gas in the fundus of the stomach. Whenever possible, the standard frontal chest radiograph of posterior anterior or PA projection is done. In normal PA, the shoulder is curved against the cassette so that the shoulder blade is away as much as possible from the lung field. Occasionally, lateral chest X-ray is used as complementary to confirm the existence or location of pathology. This is an example of a subtle opacity in the right middle zone, causing possible obscuration of the right heart border. The complementary lateral chest radiograph shows a clear collapse in the right middle lobe. Anterior posterior or AP projection, sitting or supine position, may be performed if the patient is unwell. Please be aware that in this projection, the heart appears relatively enlarged, and scapula is usually in the way. Systematic approach of chest radiograph interpretation. Now check the patient's details, including name and date of birth. These may sound pedantic, but it is very crucial to avoid reading radiographic image of a wrong patient. Noting the age is also important, as we know that certain diseases are more common in certain age groups. Having checked that it is the correct patient, check the date of the radiograph to ascertain which one you are reviewing. Check the orientation, position, and site description of the radiograph. Image quality of chest radiograph. After you have checked it is the right radiograph for the right patient, it is important to identify whether or not the radiograph is technically adequate. Without this crucial step, you may diagnose disease that is not genuine. If the image is not of best quality, but the clinical question can still be answered, a chest radiograph need not be repeated. Rotation can be assessed by comparing the medial ends of the clavicles to the spinous process of the vertebral body at the same level. Chest radiograph should be taken with patient in full inspiration. The exception is when looking for small pneumothorax, as this will show best on full expiration. A good inspiration on a PA chest radiograph shows at least 9 posterior ribs above the diaphragm, or right hemidiaphragm is intersected by the 6th anterior rib at mid-clavicular line. Penetration, the radiograph shouldn't be too dark or too bright. The chest radiograph should include the entire thoracic cage, including costophrenic angles and lung apices. And chest radiograph should be free from any overlying artifacts. This is an example of chest radiograph of good penetration. This is, on the other hand, showing underpenetrated image where the retrocardiac lungs and periphery are not well seen. This is an example of over-penetrated image where it's too dark. Lung markings cannot be seen properly. Small pneumothorax, for instance, may be missed. This is an example of a rotated image. Note that the distance between the spinous process and the medial end of the clavicles are not symmetrical on both sides. And there is also secondary current shift of the mediastinum to the left. This image is comparing chest radiograph with good inspirations versus a chest radiograph with poor inspiratory effort. The chest radiograph with poor inspiratory effort on the right-hand side shows apparent enlargement of the cardiac silhouette and crowding of the vessels. The image on the left-hand side shows incomplete inclusion, the costophrenic angles, and part of the lower zone of the right lung are not included. The image on the right-hand side shows overlying artifacts or necklace obscuring the upper zones and the superior mediastinum. Systematic review. There is no standard order of reviewing different areas of the chest radiograph. You can start from any part and have your own order of reviewing each area. Your approach may be different from other people. What really important is that the review must be comprehensive and it's done in a systematic manner so that the risks of missing a pathology is avoided or minimized. The initial reviewing process may be led by what is most obvious on the chest radiograph or based on the clinical indication. Check the trachea. The trachea is usually central. It may be slightly deviated to the right due to presence of aorta. The right peritracheal strip is usually thin. Review the lungs zone by zone and compare both sides. Look for any abnormalities such as nodules, infiltrates, or collapse. Look the pleura carefully. Is there any pneumothorax, calcification, nodule, or effusion? Assess the mediastinum. Is there any mass or air? Assess the cardiac silhouette. Is there any cardiomegaly, pericardial calcifications, or any specific chamber enlargement? And lastly, check the bones and soft tissue for any abnormalities. There are a few areas on a chest radiograph that need extra attention, as subtle changes may be overlooked if these areas are not being scrutinized properly. These areas are known as blind spots or review areas. They include lung epicers, hila, retrocardiac regions, costophrenic angles, subdiaphragmatic regions, bones, soft tissues, and edges of the radiograph. Remember, there is lungs hiding behind the heart and diaphragms. Lung abnormalities on chest radiograph. There is a few commonly used terminologies in describing pathology on chest radiograph. Opacity is used for bright lesion. Any solid mass or fluid appears opaque on chest radiograph. Lucency is used to describe dark lesion and is usually air-filled. When describing a border, for instance, one can use the term well-defined or demarcated versus ill-defined or ill-demarcated. Homogeneous may be used to describe even density of a lesion, and if it's very uneven with mixture of opaque and lucent areas within, heterogeneous term may be used. I would avoid less formal terminology such as shadow, hazy, or fluffy to describe pathology. These are a few descriptions that can be used to describe pathology. Consolidation is when there is ill-defined airspace opacity seen. Sometimes the spared airways may appear as linear lucencies, termed as a bronchogram. Summations of multiple lines may be seen and usually but not strictly implying interstitial changes, and the term reticular changes can be used. If there is mixed nodules and reticulation, one can use the term reticulonodular. When an opacity is homogeneous with well-defined, often rounded or oval in shape, depending on the size, the term nodule and mass can be used. Some may have lobulated or spiculated margin. Cavitation is when there is loosened lesions with thick wall. Cyst, on the other hand, is when there is loosened lesions but has thin wall. When there is opacity, which is very dense, similar or denser to the density of the bones, and artifact has already been excluded, then calcification is likely to be there. On this chest radiograph, you can see opacity in the right upper zone. The upper border of the lesion is ill-defined. It is bounded by the transverse fissure inferiorly, so this lesion is located in the right upper lobe. There is interlinear lucencies in keeping with a bronchogram. So this is right upper lobe consolidation. The most commonest cause of lobar consolidations like this is pneumonia. It should be correlated clinically. Other causes of consolidations include hemorrhage and malignancies such as mucinous adenocarcinoma, but they are less common as compared to the infection. This is another image. It's a focus image demonstrating airspace opacity. You can see the upper border of this left lung pathology is ill-defined. It has nice abronchogram within it. So this is a left lung consolidation. This chest X-ray shows multiple patchy airspace consolidation in both lungs. Some of them has kind of like nodular appearances. So this is imaging findings of bronchopneumonia or diffuse bronchopneumonia. There are a few patterns of pneumonia, such as lobar bronchopneumonia versus interstitial pneumonia. The bronchopneumonia or lobular pneumonia is when there's infection at the terminal bronchioles extending to the alveoli, resulting in patchy consolidation around small bronchi. It tends to be patchy, asymmetric, and segmental in distribution. It's usually bilateral, and it's caused by mixed organisms such as Staphylococcus, Streptococcus, H. influenza, etc. Lobar pneumonia is when there's a focal single lobe or multiple lobes are affected in a non-segmental distribution. You tend to see a bronchogram in the region of the consolidation, and it is mostly caused by pneumococcal infection. Interstitial pneumonia, will demonstrate reticular pattern in a predominantly central distribution. On this radiograph, you can see there is homogeneous opacity with sharp margin forming a triangular shaped lesion in the right upper medial lung zone. This is in keeping with right upper lobe collapse. This chest X-ray is showing a total whiteout of the right lung with evidence of volume loss. You can see that the trachea and mediastinum is shifted to the ipsilateral side. So there is a few differentials when you see this. One is right lung agenesis. The second one is right pneumonectomy. And the third one is total right lung collapse. So it's very important to compare if there is any previous remote chest X-ray or this is already a known abnormalities. And also look for any bone defects and surgical clips, as this may point towards pneumonectomy. But this can be easily clarified, from the history taking. In this radiograph, the abnormality is in the left lung. If you look carefully, you can see loosened area with gas fluid level consistent with lung cavitation. There is rounding consolidation. Differentials of solitary cavitation is infection and malignancy. Infection include pyogenic lung abscess and tuberculosis. Primary lung malignancy that tend to cavitate is squamous cell carcinoma. Now, the presence of air fluid level and surrounding consolidation points towards infection. And obviously, this has to be correlated clinically to see if there's any clinical sign of fever and biochemistry showing elevations of inflammatory markers. This is another example of a lung cavitation. Again, this was secondary to lung abscess. You can see very nice lucent lesion located in the left mid zone. It has irregular wall, and if you look at the most inferior part, you can see gas fluid level. Again, there is surrounding consolidation, particularly in the left lower zone. There's also an additional finding of small plaque atelectasis in the right lung. For this chest X-ray, you can see multiple cavitations of varying sizes in both lungs, mainly in the mid and lower zones. There's also small pleural effusion in the left side. There's a few differential diagnoses for this kind of presentation on chest radiograph. Number one is septic emboli. Number two is cavitating lung metastases. Number three is vasculitis, particularly granulomatous with polyangiitis, or known as Wegener's granulomatosis. Here on this chest X-ray, you can see there is opacity in the left upper mid zone. It is rounded. It has well-defined margin. So this is consistent with left lung mass. Multiple numerous nodules, opacity, homogeneous, well-defined margin, diffusely scattered in both lung fields. You can also see that this patient has a chemopod, so patient has been receiving chemotherapy. So this is imaging findings of lung metastases. In these instances, sometimes terms of cannonball lesions are being used. This chest radiograph is showing numerous tiny discrete nodules diffusely distributed in lung fields. This is miliary nodules. Differential includes miliary tuberculosis, particularly where tuberculosis is an endemic in that region, so there's a top differential. Other differential include fungal infections or miliary metastases, particularly thyroid carcinoma or renal cell carcinoma. Sarcoidosis can show apparent miliary changes on chest radiograph, but in actual fact, it is more of a perilymphatic distributions of diffuse nodules. Pneumoconiosis is another differential diagnosis, such as silicosis, but tend to have discrete calcified or high dense nodules more in the upper lobe. This frontal chest radiograph is showing irregular opacities, scarring, and bronchiectasis in the upper zones. You can see tram track line, as well as cystic changes representing the end-on appearances of the bronchiectasis. There's volume loss of the upper zones or upper lobe, causing elevations of the hila. So this is in keeping with upper lobe fibrosis. Differential diagnoses include cystic fibrosis, pulmonary tuberculosis, sarcoidosis, and ankylosing spondylitis, or pulmonary changes of ankylosing spondylitis. This chest radiograph is showing hyperexpansion of both lungs with thinning and tubular shape of the mediastinum, and flattening of the diaphragm. So this is, imaging changes of a chronic COPD patient. This is another chest radiograph of a patient with advanced COPD. There are multiple areas of lucencies, of devoid vascular markings, with walls or thin walls consistent with multiple bullae. This frontal chest radiograph is showing marked upper lobe fibrosis. Again, there is irregular opacities and reticular changes in the upper zones, causing marked reductions of volume loss. You can see that both hila is elevated. Perhaps there's some high density area in that region, representing area of calcification. Now, this case was a chronic pulmonary tuberculosis, or confirmed case of chronic pulmonary tuberculosis. But again, if I see upper lobe fibrosis, there would be other differential diagnoses, including sarcoidosis and pneumoconiosis. Pleural abnormalities on chest radiograph. On this chest radiograph, there is lucency filling the entire left hemithorax. It is devoid of lung markings. There is mediastinal and tracheal shift to the right. This is in keeping with large left tension pneumothorax. On this chest radiograph, there is lucent area with no lung markings in the right periphery and apical regions. Note is made of pleural strip representing the visceral pleura. There is mild mediastinal shift to the left. This is consistent with the right pneumothorax. On this chest radiograph, there is homogeneous opacity occupying the left, mid, and lower zone. There is meniscal sign on its superior border. There is some mediastinal and tracheal shift to the right. This is in keeping with medium-sized left pleural effusion. On this chest radiograph, there is homogeneous opacity in the right lower zone with meniscal sign obscuring the right costa running angles. This is consistent with right small pleural effusion. On this chest radiograph, there is irregular calcification projected over the lungs and along the diaphragmatic, pleural, and mediastinal surfaces. Note that the calcification is not bounded by the fissure, hence it's unlikely to be in the lung. Due to its undulation appearances, it gives rise to holy leaf sign. These changes represent pleural plaque calcification, most likely attributable to asbestos pleural-related disease. This is another chest radiograph showing similar but less extensive holy leaf sign, again due to underlying asbestos-related calcified pleural plaques. Now it's time for quiz. So get ready with a pen and a piece of paper. Please write your answer in that piece of paper according to the number of the image. I will reveal the answer towards the end of the quiz. So have fun trying. Quiz number 1. Let's move on to the next question. Quiz number 2. Let's move on to the next question. Quiz number 3. Let's move on to the next question. Quiz number 4. Let's move on to the next question. Quiz number 5. Let's move to the next question. Quiz number 6. Let's move on to the next question. Quiz number 7. Ready to move to the next question? Quiz number 8. Okay, this is the last image, and I will reveal the answers. And these are the answers. I hope that you get most of the answers correct, and I really hope that you have learned a lot from this lecture. There is another complementary lecture, which is thoracic imaging, part 2. Now, the take-home messages are: chest radiograph interpretation requires systematic approach. Accurate description of radiological findings on chest radiograph is utmost importance to reach a correct conclusion or diagnosis. Locations of lung pathology is best initially described in upper, mid, or lower zones. Specific lobe may be possible in certain cases. Use commonly used terms such as opacity and lucent to describe pathology. Look for secondary sign. Collapse is associated with volume loss. Mass or effusion is associated with mass effect. Remember to state right or left when describing pathology on chest radiograph. These are the references. Thank you and take care.